Continuing Chapter 32, the child with neuromuscular and muscular dysfunction, and we're going to look at Spina Bifida. And the different ones we're looking at, there's Spina Bifida occulta, Spina Bifida cystica, which can be either a meningocoele or a myelomeningocoele. Actually, your book calls them meningomyelocoeles. I'm used to reversing those two prefixes, so forgive me if I do that. And then encephaloceles. And this is a picture of our Spina Bifida occulta. What's happened here, this is a cross-section coming down through the spine. The head is up here, and this is down the coccyx. And you can see the meninges and perhaps some of the spinal nerves are pinched, have kind of bunched out here and are pinched between the vertebrae. They don't, however, protrude outside the skin. What you do get is the skin pulling in. This is a dimple, they'll call it, back here. This is a meningocoele. This time, the meninges have protruded outside of the skin. This comes out the child's back, and it's filled with CSF fluid, and here's our spinal cord. So our spinal nerves are not involved. When you have the meningomyelocoele, this time we have the spinal cord. Those spinal nerves are out in that sac as well. And here's just pictures the other direction. So this is a cross section cut across, looking down what your vertebrae should look like with your spinal cord inside. What we get with the occulta, we've got this opened area, but we've got just the skin kind of pinched in here. The meningocoele, our spinal cord is, or our vertebrae is pretty open, and the meninges come out and protrude outside the skin, and here the spinal cord is caught in them, and you can, this is just looking from a different direction. An encephalocele is similar, except it's on the head. We still have our meninges protruding out here with CSF filled sac. It can be posterior like this one, or it can be frontal, really anywhere protruding out between sutures, the suture lines of the skull. And here's a picture of a frontal encephalocele. Now, your book has a nursing alert saying that we should educate females of childbearing age that they need to take folic acid. We do know that folic acid in the first weeks of pregnancy, when the spinal cord and that neurotube is developing, can help prevent these birth defects, because a lot of pregnancies are unplanned, and it happens so early in the pregnancy, the development of this part of the fetus, that it's really recommended that females of childbearing age should take folic acid, whether they're planning to become pregnant or not. We also know there's a little bit of a genetic component to this, because a woman who's had one infant with a neurotube defect is at a higher risk to have another one than a woman who hasn't. Pathophysiology, there's a failure of that neurotube to close as it's developing. We get a splitting of the closed neurotube from increased pressure, from increased CSF pressure in the first trimester. About 80 to 90% of these kids will have hydrocephalus, and that's kind of a chicken and an egg scenario. So did the hydrocephalus make increased pressure that then pushed the meninge out, making that meningocoele, or did the meningocoele happen and change the flow of CSF that then increases the pressure? Doesn't really matter. Just realize if a baby's born with some sort of neurotube defect, we're probably going to need to put in a shunt. There's probably going to be hydrocephalus. So you can see here the dimple. So there's nothing, no meninges protruding out, but there's this dimple in. So clinical manifestations, what do we see? That sac is very delicate, and we want to try and prevent tears to it. We've just, opened up the CSF to, allow bacteria in if that sac does tear. So we want to try and minimize or prevent tears to it. These are usually lumbar or lumbosacral. They can be higher up, but most common would be lumbar. And realize if we're talking below the second lumbar vertebrae, you're going to have paralysis of the lower extremities at that point. These kids very often will have defective nerve supply to the bladder, so you get a neurogenic bladder, so the bladder doesn't function. They can develop joint deformities in utero. They're not having normal movement, so you don't get normal development. Particularly hips can be a problem. And then a dimple there on the lumbar or coccyx area, that may be our non-cystic spina bifida, the spina bifida occulta. So therapeutic management. There is something new, trying to do surgery on the fetus. It's fairly new, and I don't know that it's readily available in our area on meningomyelocele. Early closure is the normal treatment, and your book says it should be done within 24 to 72 hours, and that there's even a shift going on where it's more like 12 to, I think it was 12 to 36 hours or something like that. So even earlier is starting to happen. Remember, 80 to 90% will have hydrocephalus, so we're going to have to monitor for and treat that. And management does require a multidisciplinary approach, because we're probably talking about bladder, we're probably talking about mobility, we're probably talking about hydrocephalus. I mean, there's a number of different specialists that physicians, subspecialists who are going to be involved. So the orthopedic considerations with this, depending on where it's at, there's a good chance they're going to have no use of their legs. So we want to prevent contractures, we want to correct deformities, and we want to prevent or minimize effects of motor and sensory deficits, prevent skin breakdown. We want to get them the best possible functioning they can, and we can do that with braces, special walking devices, custom-built wheelchairs. It's really amazing, what in rehab they come up with all sorts of creative ways to get these kids mobile. Now, I said this is a common cause, or commonly these kids will have a neurogenic bladder, so they can't really control their urinary function. So we do want to try and preserve the renal function, and we want to optimize urinary continence so they can have they're typically very normal kids cognitively, so we want them playing with and interacting with other kids, so trying to control that urinary continence. Treatment of renal problems, treating UTIs, because they can't really void fully and empty their bladder, and they're going to be at risk for UTIs. Most of them will need to do clean intermittent catheterization, so we're going to teach the family to catheterize them. And the interesting thing in that, when we do intermittent, just those in and out catheterizations in the hospital, we do them sterilely. When we teach the family, we teach them to do it clean. At home, it's the family germs. It's the germs this child is exposed to every day, and they have antibodies against them. In the hospital, it's a whole new batch of germs that their immune system's never seen. So we do it sterilely in the hospital, but we're teaching clean at home. And then as the child gets a little older, they're doing catheterization. There are some medications to help improve bladder storage and continence, and again, as they get a little older and are, interacting with other kids, we may need to use those. And often, as a child gets older, doing that in and out cath on yourself is awkward. So sometimes they'll put in this. It's an opening into the bladder so that they can do the catheter. Usually it's at the umbilicus, usually it's at the umbilicus, so they can catheterize themselves through the umbilicus as opposed to having to go through the urinary meatus. That's a Mitrofanov, and you can see actually that kid looks like they have a G-tube in. I don't know. That looks more like a G-tube there, but I thought it was supposed to be the Mitrofanov. Okay. Bowel control is also a problem. Again, they really can't feel when they need to go. They can't really push to expel a bowel movement. Often we can get these kids pretty well regulated, though. We may have to add a lot of fiber into their diet to have nice bulky stools that will be regular. We're going to try and prevent anything like constipation or impactions, because remember, they can't really push to get those out, so we may need to use laxatives, suppositories, or enemas. And similar to the Mitrofanov, there's an antegrade continence enema that we'll do on some of these kids. And they'll take the appendix or right there at the ileum, and they'll create a catheterizable channel to the proximal end of the colon. So every day or two, depending on what their bowel habits seem to be, they give themselves an enema, but again, it's easy to get to. It's not trying to do it through the rectal sphincter. And so they'll do the enema solution, and within 30 to 60 minutes they should have a bowel movement. And that way they don't have to worry that they may have a bowel movement, because they can't feel it until it's come, when they're out in public and playing with other kids. Nursing care, we want to prevent trauma to the sac. We're going to keep those meninges sterile and moist until surgery happens. No rectal temps, because there is a risk of a rectal prolapse. Feeding is the big issue. We're going to keep these kids prone, so they're hard to feed before surgery. If they go just a few hours after birth, they're probably not going to feed before birth, but if they're waiting 2 or 3 days, we're going to need to feed these kids. So keeping them prone and just kind of turning the head to the side. And it's not an easy thing to do, to feed them. Diapering is contraindicated until they've had the surgery. We don't want a diaper rubbing on the meningocele. But remember, they're still an infant. They still need to be touched. They still need that tactile stimulation. Hydrocephalus is a problem, so we're going to be monitoring head circumferences. We are worried about meningitis. I mean, this is an easy route into the meninges, so watching temperatures, watching for signs of that increased intracranial pressure. And these kids, up to 80% will develop a latex allergy, so we usually put up latex allergy immediately and don't give them the chance to develop it. And that's the end of this section.